Nankari Nangi, everyone. Welcome to the Race Grand Round. My name's Professor Paul Worley, and I'm speaking to you from Ngarrindjeri country. And it's a great opportunity for the Riverland Academy of Clinical Excellence to come together, to be challenged by thought leaders from around the world, and to examine how those thoughts and ideas can make a difference where we work and live and where others work and live, to expand our horizon of possibilities. And today is like previous, another opportunity to think more broadly about what it means to provide rural healthcare. We know that rural healthcare involves teams, and we usually think of those teams as professionals who have been trained in universities with clear qualifications and strong regulatory bodies that are looking after the safety of the community. However, increasingly, we are looking at broadening that out to involve consumers as part of the team. And in particular, when it comes to mental health, people who have lived experience of the illnesses and the stress that our patients and clients may be suffering can be part of the team. So how does this work? How can it be? What are the advantages of this? What are the prerequisites to make sure that it's successful? Thankfully, we have an expert on hand to help with this, and this expert happens to be in our backyard. Professor Sharon Lawn is a professor of mental health at Flinders University, and also has a national leadership role in the lived experience peer worker field in Australia. So it's a great privilege, Sharon, to welcome you, knowing that at the moment we are actually collaborating with your team in a clinical trial of lived experience peer work in general practice that will, as well as around Australia, involve a practice in our region in Renmark. So thank you everyone for attending, and thank you, Sharon.
Yeah. Thank you, everyone, and thanks for inviting me, Paul. As Paul said, half of my time I still do a whole stack of research at Flinders, and a lot of that research has always been a mixed methods, but particularly qualitative research, bringing the consumer voice and the family carer voice to the mix. I will just get rid of that so it doesn't keep jumping up. So yeah, for the last 20 years, I've certainly done lots of research on self-management and self-care within chronic condition care planning. Before that, I was a clinician in mental health and disability for quite a long time, and have had about 20 years as a mental health carer and my own mental health as a younger person. So this particular journey, I've actually just come back from Renmark last night. We ran a workshop ready for a trial, as Paul said, that we're doing, which is the first really to properly trial what we can learn about bringing general practice and peer workers together. So by mental health peer workers, I know some of you may or may not know too much about mental health peer work. It is people who have a lived experience, so people who have experienced receiving services from the mental health system in whatever form that's been, and they've done the journey of their own personal recovery and are living well with their mental health issue. It's not a new phenomenon. If you look back over many decades, We've always had aspects of peer support. The 12-step program, for example, is probably a well-known example of peer support. There is a very strong international focus on mental health peer support. There are some very prominent people who've been doing research and advocacy for many decades, for example, in the US and in the UK, etc., and also now here in Australia, particularly in the last 20 years or so. So, interestingly, in the workshop last night, we had a number of GPs and psychologists and peer workers and clients of the practice who we all came together to actually start the process of thinking, what would the model of care look like in general practice, ready for this trial that will commence in about 2 months' time from now. So we're doing this formative work around, the nuts and bolts, the practicalities of this process. And there were a number of the usual questions that come up around risk, around boundaries, around safety, around what happens if something goes wrong, what happens if the person becomes unwell, will the peer, what will their interaction be like? So lots and lots of questions because there's not a lot of knowledge, I understand, around what peer workers do. So, there was quite a detailed discussion around that peers actually have quite significant structures there. They are very, very closely supervised. There's very extensive training. Increasingly, they are undertaking a Cert 4 in mental health peer support, which is a dedicated national program. The community managed organisations across Australia, which are being, at the moment, we're about to launch nationally, the Commission on Safety and Quality are about to launch the standards, accreditation standards for CMOs, and the role of peers and the services quality delivery generally will be part of that process. In peer work, there is a very strong focus on mutuality, reciprocity. Their core values are non-clinical, providing trust, engagement, completely from the consumer's perspective, more holistic focus. They're not there to ensure that people are compliant with their medications, for example. They're not there to. They're not a activity advisor or a activity aid. They actually will sit down with people. Sometimes they will go along to appointments with people just to help people find the words. We talked last night around a range of the evidence, because the GPs were very interested in, what's the evidence for peer work? And luckily we were able to share that there are a number of very well regarded projects, research evaluations that have been undertaken here in Australia and overseas. There's a number of reviews and systematic reviews now that have been done on the evidence for peer work. And what, the key messages that resonate across that are that peer, there's no further harm, for example, by having a peer involved. So the results are as good. So that's a tick. They do. There's other elements where certainly services save money, but there are many other benefits that have been found from research. They certainly improve engagement in services, because something which is relevant to this project, the practicalities that they will fill that space in between where people often fall through the gaps. So where people are lost to follow up because they got home from a hospital environment and just felt too overwhelmed and didn't follow through. So then, the further follow-up appointments or whatever just never got made. They may be put on a mental health care plan by their GP and then, go forth and find a psychologist and off you go. They may never have made that appointment, or they may have dropped out after the first appointment. They may have been given information of, community connections to be made, but as we know, many people need someone to walk alongside them in order to get out of the house, in order to go to that gym for the first time, in order to make the connection, whatever it is, of something for the first time or ongoing. So peer workers very much do all of those things because they've walked that walk and they understand from the person's perspective that lived experience of the challenges. They do many, many things in their role. They're employed, supervised, trained across just about every part of the mental system. They go out with ambulance staff, for example. They're located in emergency departments. They're located in forensic inpatient settings, in the broad range of mental health inpatient settings, in community settings. They increasingly are delivering a lot of the NDIS psychosocial support to people across Australia, and very much a growing workforce. So that's some of the general sense of it. Now, I'm conscious I've only got about 30 minutes of time with you today, I think, haven't I? So I'm wondering if it might be a good idea to open up to some questions, and we'll try and keep it practical.
Great.
Yeah.
Thanks, Sharon. That's a really helpful introduction. So I'll start with a question, and then we'll let others who are synchronously online with us get into the questions. So yeah, you'd be aware of a number of other lived experience groups. So Cancer Council, cancer survivors, lived experience groups. There's the Diabetes Association. There's a number of rheumatological, arthritis groups, and all of which seem to have, a fabulous input to people who are caught in the middle of the maelstrom of care. But most of those others don't get paid.
No, and
So
that's
what's different about the fact that these people are employed and trained as opposed to the cancer survivor networks and those other groups?
yeah.
Why do we need that in mental health?
Yeah. So, many systems are complex, but mental health is particularly complex. And unfortunately, it's one of the areas of healthcare where, it's one of the few systems where people are locked up in order to be cared for. is one of the bottom lines. So unfortunately, many people, particularly in the lived experience sector where I'm, my other half of my life is running a national mental health consumer care advocacy peak called Lived Experience Australia. Um, and, many of the reform activities that are ongoing are about reducing coercion in care. So, people may well know and I'm sure that in your work you are well aware of the Mental Health Act variously that you probably have to be part of delivering. Yeah. So it has a unique place. And with that comes very significant trauma for people, for families, potentially. It is a system which is very, very particular about confidentiality because of the stigma of mental health conditions. So, unlike if if I have a family member that develops a cancer diagnosis, it's very intuitive and logical that the specialists involved and the health professionals involved will include family. That just doesn't happen automatically in mental health. So, it's one of those systems where straight away you have inbuilt fragmentation and exclusion and siloed care, and mistakes can get made, things can't happen sometimes. I know in my own house, I'm the magic fairy navigator that fills the scripts and fills the dosettes and soothes the mind of my husband every day of the week. But if that wasn't there, then who do they think actually does it? Um, so uh, so there's some unique differences between those other systems. Um, whether it's someone with dementia, whether it's someone with cancer, whether it's, there is that quite distinct difference. So the person is pretty much on their own in a lot of their contact. And, there are good reasons why there may be, family trauma, etc. So there's a whole lot of complexities that mean issues like trust, stigma, coercion, uh, unfortunately can be part of the person's experience, and probably disproportionately compared to other systems, because if you have usually when you get a health diagnosis you willingly want to go and fix it. Yeah, that's not always the case in this area. So you need people who understand that, and peer workers who have lived that journey themselves and can be connectors to others. They're the absolute glue between systems. It's a really interesting role because, unfortunately, systems have procedures, they have rules, they have all these processes. We like to separate out expert from patient or client, knowledge basis, very distinctly. Whereas peers, they sit in the between space. They sit in quite a liminal space. So not only are they an employee, but they're also an advocate for the person in many respects. So that's where, many of the work that is currently being researched, understood, practiced is about involving peers for the expertise in lived experience in multi-D teams, which have been traditionally hierarchical, for example. And so we know that even, allied health can sometimes be struggling to get an equal voice in the contribution of holistic care in multi-D teams. And peers are another layer again of that. Um, Yeah, it's a very complex
Yeah.
system
Thanks,
and
Sharon.
really
That's really
interesting.
helpful. Really helpful. So are there questions from anyone around the LHN who's online? Um, I can see hands if you put up a hand, but otherwise there's a hand. Okay,
And
that's
Sharon.
someone introduce yourself, please, and ask the question.
G'day, Sharon. How you going? I'm Nathan. I'm an intern up in the Riverland. I'm working in the Renmark GP. I'm just going to switch the camera off so I can sit down. Thanks for the presentation. I think it's a great idea. There's lots of people within the community that I might there's always people that lots of people generally trust, and once you join a community you very quickly find out who those people are. For example, they might be in community clubs or sporting clubs or things like that. If, for example, we think that they might be good at this job, is there, for example, they might ask me straight up, sure, how much time's involved? What qualifications do I need? So I know that you said they might need a Cert 4 in mental health at TAFE. Is that a kind of hard and fast prerequisite? And just how much time would it be involved?
yeah, so for this particular trial that we're doing, the peers are actually going to be coming from an existing employed role in a community managed organisation. So Skylight in Adelaide. But yeah, just about every day of the week I get a call or an email from someone who has had a mental health experience of coming out of hospital, of they have this strong desire to give back. They want to make sure that other people don't have the experience they've had sometimes.
Sure.
So yeah, there are many people on the journey that say, I would love to be a peer worker. Yeah. There are a number of people who are employed in roles that are either doing the Cert 4 or have done the Cert 4. The sector's actually playing catch up, really, at the moment. It's a workforce that, like, there's national guidelines that have been developed. There's a professionalisation process that, is being advocated for and built on. There's a lot of energy happening. So for someone in the community, like you've mentioned, they wouldn't have a role in this particular project. But the best thing that they can do is to, for example, reach out to an organisation like ours, Lived Experience Australia. We do a lot of, there's a whole lot of activity in the lived experience world where people like us, we run webinars, we run free workshops, etc., where people who are on the journey, how do I become an advocate? How do I use my lived experience? So in the Cert 4, some of the topics are actually about how to share your story safely, for example, because not everyone can just instantly be a peer worker just because they've had a lived experience of a mental health condition. So, it's about not re-traumatizing yourself, not re-traumatizing others. Do you know what I mean? Overexposing. I deliberately don't share a lot of detail of my own lived experience because it involves, hostage stuff and all sorts of things. So, I'm not going to re-traumatize myself or other people in that. So the person that you're interested in telling them about, well, how you're interested, this is what you can do. Get them to link in with some of the advocacy groups and the work. There's a whole lot of it out there. There's many informal and formal consumer and family carer advocacy groups across the country.
All right. Fantastic. Thank you very much.
Thanks, Nathan, for that question. Are there other questions from what strikes me, Sharon, is sorry, I was going to ask a question, but Dave's got a hand up. So, Dave.
Hi, Sharon. I'm Day. I'm the Director of Nursing in Manum and Karoonda, so 2 small country sites. And my question was around, it almost feels as though there's an expectation that people will be traumatized in our services, and I find that really concerning. And this question doesn't specifically relate to peer support, but to what we do and how we do it best. How do we avoid that? What are your guidelines to us as small country sites without necessarily having mental health specialists available to supporting people who attend our services? And then a secondary question on how would those people possibly later access a peer support?
Yeah. So absolutely, my comment about coercion and trauma is absolutely not everyone's experience at all, but it's one of those things that happens for some in mental health, and it does get a lot of airplay and mileage. But of course, there are many people who just the experience itself, whether it's through having a psychotic illness or having, significant depression, suicidal issues, it's finding the words themselves and having the time being asked or not being asked what they need, not knowing perhaps, there's assumption that, if you do a needs assessment, someone's going to be able to articulate that, and that's not always the case, is it? So, and just the everyday things around confidence and self-worth, and, there are many things that a peer can sit with people and have time to talk from a daily lived experience perspective that are valuable, let alone being sensitive to people who may have experienced more adverse issues around their mental health experience of seeking help or not seeking help. And peers can actually encourage people to seek help, by building that bridge for them. So I'm not sure. Your question's an interesting one, because obviously in rural areas you have that added dynamic of small communities. So, I know I did some interviews with some volunteer firefighters over on KI, and it was like, we don't turn up at the therapy because it'll be all over the town by the afternoon. So, and there are issues around confidentiality and boundaries and things which are probably unique in rural areas in relation to any type of health professional role, let alone a peer role, when you live and work in the communities and have relatives and friends in those communities. I'm not sure if I'm answering your question.
I think it's possibly is a difficult question to answer, but I think what I'm hearing you say is that for us, in the first instance, the thing that we can best do to serve people is have empathy and time to
time is
just
a big
be
one.
with somebody.
Yeah.
I think that's what I'm hearing you say. Yeah. I was also interested in how our people can access the peer support.
So, unfortunately, at the moment, there isn't a mechanism for primary care because of the various funding silos. And that's why projects like this one are important, because we just, there's not the strength of the evidence base. So we don't even know, how much GPs know about peer work. So regardless of the actual trial and the the effectiveness aspects, etc., we're going to learn a lot about bringing these two worlds together a bit, and what are the enablers and the barriers. They're actually really practical things. So at the moment, funding constraints and silos really are problematic. But you can well imagine, and we talked last night, people who may be returning from hospital to home. I set up a hospital avoidance early discharge peer service here in Adelaide about nearly 20 years ago. And it was hugely successful because people, particularly for rural people who, may have been sent down to Adelaide to hospital and then, 5 weeks later come home to a house where, they open the fridge and it's all a bit overwhelming and the letterbox is all a bit overwhelming, let alone the first appointment and connection back to GP. And peers had time. They had time to walk alongside people to do that stuff when there weren't other supports. But these things happen within projects at the moment rather than actual dedicated programs. So the Department of Health people in Canberra are very interested in this project. I connect with the workforce department people each month because of our peak organisation role, and they do want me to present on this particular project. One of the Queensland clinics that are involved, the CMO there and the clinic met recently, and one of their first questions was, when this trial finishes, we should talk about how we can actually service each other's needs, finding a way. So I think it's a watch this space, is a long answer to your question. The mechanisms at the moment obviously are not there as far as relationships with providers in the community, MBS, all of those systems. But, it's a very movable space, isn't it? Yeah.
Thank you.
Thank you so much, Professor Sharon Lawn. What I've heard is the importance of humanity and the importance of trust. And I guess the one advantage that we now have is that we know someone we can go to if we want to find out more about this in terms of you and your organisation. And thank you very much for sharing your rich knowledge that's come through decades of experience in this and opening our eyes to better options to care humanely and personally for the people who are suffering from mental illness in our region. Thank you everyone for engaging in this, and I'm sure the conversations will continue well after this presentation finishes. But for now, Nakanya, and thank you very much for being part of this this race grand round.
Thank you.
Thank you.